and make sure you have the answer choices so you can respond really quickly. And then I'm going to take the vignette and I'm going to change a detail of it. And so it's going to change what the diagnosis is. So hopefully, are we good to go? Okay, I have the chat open as said. So we're going to do these mini vignettes focusing on differential diagnoses. And so we got Staph aureus, Strep pyogenes, Pseudomonas, fungus. We're going to see different funguses, and so I'll identify what type of fungus for the different cases. Mycobacterium leprae, Clostridium perfringens, herpes viridae. That includes a lot. The major ones that are covered in skin and muscle are going to be varicella zoster, HHV 6 and 7, HHV-H was composite sarcoma, and then we have measles, rubella, and Coxsackie. Okay. So let's go ahead and I'll just read fast. And again, you guys have the PDF available. 12-year-old boy developed a fever, dry cough, runny nose, bilateral conjunctivitis. 24 hours later, the fevers reached 39.1 and other symptoms have worsened somewhat. Very much you need to know about vaccination status. I would immediately look in the mouth for Koplik spots. We see in the history 3 weeks of travel of this family through Southern Europe and Northern Africa. So really concerned about endemic transmission. We see a lot of pharyngeal and conjunctival inflammation, swollen non-tender anterior cervical lymph nodes, and a macropapular rash on torso extremities. Images are very, very important. Macular is flat, papular is raised. So if you run your hand over this person's skin, it's going to have a contour. And I provided links as well. This is on Access Medicine. I have modified it just a little bit. So this is the case. Go ahead and get your clickers out. Okay, so which of the following is the most likely causative agents? And we're going to be doing it pretty quick. Pulling closed. Oh, I clicked it. Let me go back. Let me go back. Escape. Oh, I'm getting all right. Sorry for my advancer. I was using my touch screen. So anyways, coming back to this, sorry, you didn't get your answers. There's no recording on here, but the correct answers was measles. So I'm just coming back right here and just noticing that the particular details about why this would be measles. You would ask about vaccination status, so that might be a detail. We are seeing that they're traveling somewhere where it is endemic. Really pointing out that there has a high fever. We're seeing the C, the cough, the coryza, as well as conjunctivitis, and so this is going to be measles. If you looked into the mouth, you would likely see Koplik spots. All right. Sorry, a bit late. Where can I find the PDF and the session code, please? It's Harrington 2020. And can somebody just post the PDF for me? Okay. All right. No, cancel. I don't want to end the meeting. All right. And as well as let's see. So that was measles. Let us change that particular vignette. So we see that we've got a cough, dry nose, but the temperature has changed. Thank you for sharing the PDF. So here we have the temperature has changed. And so that's a much lower temperature. And we see that after that 24 hours later, the symptoms, the cough, the itchiness of the eyes are going down. We do want to know about vaccination status. And here I'm stating that this person had vaccinated from vaccines. And so looking at that previous case that was measles, the rash is the same, but we're seeing mild inflammation. We're seeing mild swelling of the cervical lymph nodes, but the rash is the same. So we took the case, but we changed details of it. And I'm really stressing about this, that we're saying that it's mild. Hopefully I'll get my timer. Okay, so yeah, polling is open. Go ahead and submit your answer. Okay, I got 27 answers and I'm just clicking through. I think my animations are off. Yeah, so the correct answer for this one is going to be rubella. For that first case, it was measles. We see the high fever. So that's a really important association for these viral. Whenever we see high fever and the CCC and the rash at the same time, that's going to be more of our true measles. Whenever we see a situation where it's a milder presentation, we have a low fever, and very, very importantly, if the rash goes away in about 3 days, it's going to be a really fast transition. So that's going to be rubella. These two are difficult. I'm just going to put these two are difficult to tell apart, but I'm just going to say if the fever is high, it's going to be this one. If the fever is low, if it's mild, that's going to be our rubella. Conflict spots will be available on measles. It's going to be white, grayish, looks like grains of sand on the mucosa. In the case of rubella, not present. Sometimes you might see red spots on the top, but it's only about a quarter. I do want to show you that this is the virus algorithm. We introduced this in term 3. And so whenever we're looking at the difference between, here would be our envelope, this is going to be our rubella. And so rubella is going to be our positive RNA. This is very, very important biology. In comparison, our negative RNA, that's going to be our paramyxo, our measles. And so it is important to integrate this algorithm because sometimes you'll see a macropapular rash and an intermediate fever, and then the vignette's going to tell you, oh, it's a positive RNA envelope. That's going to be a rubella versus it's going to be a negative RNA envelope. That's going to be measles. So trying to integrate this algorithm. All right, so yeah, I have the chat open. You're welcome to ask me questions as we go along, but I want to keep it a pretty steady pace. All right, so here we have, this is actually a vignette that I showed you over the summertime. A 50-year-old man with a painful lesion in his mouth worsening over a 2-month time period. So the fact that we're talking about something really long, that's not classic for a typical bacteria or viruses. Viruses are usually quick. Here we have in the case, it's chronic gingivitis. We're seeing a single lesion of the buccal mucosa, and I would describe this as a draining lesion. We see a regional edema and lymphoadenopathy. I'm going to go ahead and just point out this halitosis. That's an important clue. And that we've got some draining sulfur. I'm going to go ahead and give you the answer to this. This is actually actinomyces because I already gave you this case during the summertime. It's an atypical bacteria. It's filamentous. The actinomyces can also cause some granuloma diseases that are overlapping with our funguses. But I showed you this case. This is actually the link of the original case. Now let's change it. Let's change some details. So we have a lesion that's not painful. We see this over a 3-week time period. I'm going to go ahead and highlight, absolutely you should be looking at the white blood cell count. Labs are not provided in these vignettes. Now we're seeing a history in intravenous drug use. So that's very, very different. Gingivitis, that was associated with our lumpy jaw. This one, we're going to start asking about somebody's HIV status. Here we see extensive, and I just knocked out regional. That means that they have lymph nodes swelling everywhere. So there's something else that's going on. And I'll go ahead and point out white patchy lesions are noticed on the oral palate and fingernails. And so there's an additional clue that are really suspecting that this person has HIV, which is an underlying condition. Okay, so let's get your clickers out. Okay, we see a lot of distribution. I'm going to go ahead and walk through why these answers are not correct. In the case of Staph aureus, it's too long of a presentation. It's over weeks. Most of the time with Staph aureus, you're going to be seeing a really 24, 48 hours. It's a typical bacteria. In the case of Pseudomonas, I'm just going to point at these two, the bacteria, those are going to be presenting roughly in about 24 to 72 hours. It's roughly in about 1 to 2 days. They're not going to be taking weeks for them to be having this infection. In the case, I'm going to go ahead and get you to the correct answers. This is actually going to be HHV8, also known as Kaposi's sarcoma human virus. Coxsackie, I'm knocking this one out because Coxsackie is going to be presenting over a day to 2 days. In the case of fungal, this is absolutely a potential differential diagnosis. Just coming back, so just looking at our particular vignette, whenever we see that this 3-week, you could start asking about fungus. In this white patchy lesions, I'm actually describing candida. And so that might be a possible sort of a co-infection that's going on. So this person has HIV. This is actually the lesion that gives the answer, and it's painless. We're actually looking at a purple or silver, and so that's a Kaposi's sarcoma, and this just doesn't look like anything else. Usually the funguses are going to be having Yeah, it looks granulomatous, and so it's going to be more kind of a yellow bumpy, but because we see this purple lesion, that honestly is going to be giving our correct answers that it's Kaposi sarcoma virus. All the other stuff, why is it not fungal again? Because it's purple. I just want to say that that fungal is a possible answer, so I'm just saying right here, because I'm mentioning about that there's candida infection going on, which is fungal, but the purple painless, that's going to be Kaposi sarcoma. It's an overgrowth of our endothelial cells. And so if it was fungal, there's going to be some pain associated with it. But fungal is not an incorrect answer because I was mentioning about candida. That's going to be oral thrush that we see in this patient, always a clue about HIV. So purple, Kaposi sarcoma. Okay, so this one, I already gave you guys this vignette, so I'm going to run through it quickly. A 51-year-old male patient who works as administrative assistant reported asymptomatic lesion, so there's no pain associated, on the fifth finger with 5 years evolution, something very atypical is going on. And so that duration is going to be very important. What were they exposed to? I'm going to go ahead and highlight the major clue right here. This is not a common infection. So when we say somebody's got an aquarium, that's really important. We see that it's a single plaque. We've got some crust associated with it. The answer to this is Mycobacterium marinum. So I already gave you guys this vignette. That's whenever I give you the answer. But using this as a differential diagnosis, let's change some details of it. So here we see a 51-year-old male patient has a painful lesion on the fifth right finger over a 4-week duration. So the 4-week duration, that's going to be a really important clue here. We're seeing now, we're talking about gardening. So the history changes very much. We're seeing this particular picture that we're seeing granulomatous lesions. Just pointing out, they started on the finger and they're progressing, and you're seeing the streaking going on. And there's not that many things that can cause that. So streaking red inflammation along the lymphatic tract. Get your clickers out. Yes, absolutely. This is going to be a case of a fungal. And so Staph aureus, I would say that's possible, but if we're talking about granulomas, you're going to be talking about CGD. Most of the time, Staph aureus causes abscesses, sporotrix, that is the correct answer for this one, or sporotrichosis, especially whenever we mention about the gardening and the lymphatic streaking. There's just not many things that cause that. The fact that it was over weeks, that was be fungal. The case that we see that's a single lesion, that it moves down along the lymphatics, very important. This particular organism is dimorphic. And so if we actually take the sample, the biopsy from the skin, look for the yeast. If we grow the sample, the patient sample, yes, it falls under fungus. Sporotrix, it's a fungus. So just point out, this is the virus algorithm. And so we're seeing this superficial subcutaneous, it's going to be sporotrix. So you're going to be seeing, oh, sorry, my bad spelling, yeast in the beast. That's what you're going to be seeing from the skin sample. It's going to be yeast shaped with a cigar. It almost looks like, I think, a Popeye, like holding his cigar out, and it's going to be the mold. They almost look like little flowers at our 25 degree. Very important for our dimorphics. Our dimorphics can cause diseases in our healthy individuals. So yeah, those dimorphics can cause disease in healthy individuals. All right, so here is a case that I gave you over the summertime. 4-year-old Caucasian girl brought to the hospital with her parents because of fever, rash, bilateral conjunctival infection without eye discharge. In this particular case, I would ask if there's a cough, if they were vaccinated. And so this could be morphed into a measles case. This one, we talked about it from the summertime. Whenever we just now talk about tick, we learned just briefly about rickettsia, Rocky Mountain spotted fever. You're gonna be learning that with multisystem, but It's also important because you're going to be seeing the rash on the hands and the feet, and they're very, very, very sick. So the rash on the hands and the feet, there aren't that many organisms that cause that. So I would just put at this particular point, you would start asking about measles, but measles is going to be macropapular. In the case of Rocky Mountain spotted fever, so rash on hands and feet, it's going to be petacial. It's like somebody took a red marker and just drew little dots. It's a lot of like damage to the endothelial cell. Let's go and take this case. I could change it a lot of different ways, but let's focus on what we studied here. A 4-year-old Caucasian girl brought to the hospital with a fever, itchy rash, and a cough. That's an important clue. If I had just said rash, maybe think measles, but when I say itchy rash, it just changes. The child attends daycare, has incomplete vaccination history, i.e. has not been vaccinated. So vaccination status, that's a really important clue whenever we talking about these different, especially viral xanthams. The patient appears responsive and alert, and so it's not a septic infection. We see this asynchronistic vesicular rash is present. So very much pay attention to petacial, macropapular versus vesicular. Just noting that whenever it starts out flat, and so that would be our macular. It now becomes raised, and that's papular, and then it becomes vesicular. The vesicles, of course, have a lot of virus, and then they're going to crust over. So that's what we mean by asynchronistic rash. And those itchy and asynchronistic rash are going to be really, really major clues to help you out with this one. So get clickers out. Yay, excellent. So herpes viridae, yeah, that asynchronistic itchy rash, that's going to be our varicella zoster virus. It causes chickenpox. We absolutely have a live attenuated vaccine that's associated with it. I just of note that if we see an elderly population, you're going to be seeing the shingles, and shingles is always preceded by a very, very painful, it's like electric because the virus is replicating in the nerves, and it causes that innervation of the nerve. So very much, it's a very painful rash for reactivation of shingles. Varicella zoster, you're going to be seeing the cough associated with it, and that's a form of transmission for that particular virus. I just point out that Staph aureus and Strep pyogenes, they are important for individuals who have chickenpox, because what can happen is they can get a secondary infection. And so probably for the upcoming exam, you're only going to be focusing on one virus, but a lot of the times that what happens is the rash, the child itches it, and then they can get a secondary Staph aureus and Strep pyogenes. You're really going to be paying attention to pus. And then so whenever there's like a lot of pus and it's no longer vesicular, but it's pustular, that's where we're going to be talking about our secondary bacterial infections. Okay, so looking at our DNA virus algorithm, I just want to point out that we have our herpes. These guys are enveloped. Versus, say, for instance, parvo, that's going to be slap cheek. That's going to be, these guys are, the parvo is naked. And we're going to look at one more virus. In the case of pox, it's going to be synchronistic, that all of the vesicles are going to be erupting at the same time. HPV is painless. It's painless. It's going to be like the cauliflower light. But these algorithms will help you figure out some of these rashes as well. So let's go and take this vignette, and we're just change some details of it. A 4-year-old Caucasian girl brought to the hospital because of fever, rash. I'm just going to say cough is possible. There might be a GI symptom associated with this as sort of the initial entry point. Where's the rash located? Now we're seeing it on the hands, but we're also seeing it on the feet. We're seeing it on the mouth. The child attends daycare, and they're up to date on their vaccinations. And so we're going to be sort of ruling out, thinking about our measles, thinking about rubella. So whenever they're vaccinated, we're just going to be ruling those as a differential diagnosis. Patient appears responsive and alert. But the vesicular rash, that is all, it's going to be all over. But this is kind of our, mouth. There you go. That picture is really, really important. Where is the rash? Whenever we see rash on the hands and the feet, there aren't that many rashes that will be like that. And so because we see a pustular, that's going to help us. I'll go ahead and open this up. Hopefully I just gave you guys the answer for this. I just had a question, I'll answer it. All right, I think I got all the responses in. Yeah, absolutely. Coxsackie A. Coxsackie A, a lot of times is going to be preceded by a respiratory or GI symptom because the enteroviruses, that's how they get in. But the rash is the predominant, or sort of the major target for it. So Coxsackie A, you're going to see hand, foot, mouth disease. You also see that herpangia, and so it might just be in the mouth. In the case of herpangia, sometimes it's hard to tell the difference between our herpes, because herpes can have lesions inside of the mouth. They're going to be about a 24 to 48 hour onset. And so how do we tell the difference between Coxsackie A herpangia versus our herpes simplex, which I don't think you've studied yet? You just have to know the biology. So herpes is going to be DNA enveloped, versus our Coxsackie is going to be naked RNA. So question, which was painless in the algorithm? HPV. Just to clarify, Picornaviridae. Picornaviridae is the, that's the family, enterovirus is the genus, and Coxsackie is the species. So yes, picoRNA is small RNA. Those are positive RNA, includes a lot of them. Enteroviruses fall in that picoRNA. And so it's enteroviruses, poliovirus, Coxsackie A, Coxsackie B, and other enteroviruses. There's lots of them. Okay, yeah. Feel free to ask questions on the chat. I have it open and I can answer questions. All right, I think I just covered all my viruses. I had varicella zoster showing as chickenpox. I had Kaposi sarcoma that we saw a purple lesion in the mouth that was painless. We have measles, which is going to be high fever and macropapular rash at the same time. Rubella is low fever and macropapular rash at the same time. I got Coxsackie A, hand, foot, mouth disease. That's usually a pretty easy one to diagnose. The other one that I did not have is going to be HHV 6 and 7. HHV 6 and 7 is the high fever, and then it goes down, and then the macropapular rash. And so the combination of how, I'm just gonna put on here, measles is, it's high fever. I'm just gonna put temperature plus the rash. This is going to be low fever plus the rash. In the case for our HHV 6-7, it's going to be the high fever. And I mean, really high fever, usually in a toddler. And then the rash, the fever goes down. There's no rash associated. Do you get fevers with these? Absolutely. With HHV 6 and 7, febrile rash is very common. It's actually, I think it's the number 1 and number 2 cause of emergency room visits in a pediatric population. So anytime that we have that 104, that's very, very serious. HHV 6 and 7, they'll have a high fever and no rash. In the case of measles, they can also get febrile seizures, but they have the rash at the same time. So yeah, those are really good questions associated with them. And again, the fever just goes down spontaneously, and then the rash comes. HHV 6 and 7 is very, very common in the pediatric population. Sorry, I've got my cat. I got a new, this is my little new cat adoption who likes to have, go away, kitty. Okay. The other one, Parvo B19, that one is going to be having usually a low fever and a cough and upper respiratory, and then the rash. It's going to be slapped cheek. By the time they're presenting with the rash, the virus is actually gone. We're most concerned about we're talking about people getting aplastic crisis if they have an underlying blood disease such as sickle cell, as well as our usually I think of a elementary school teacher having arthritis when the kids have the rash. That Parvo B19, we're very concerned because it causes congenital disease. So HPV is painless. HPV is painless. HPV is painless. Those are going to be our wart-like lesions. And I'm pretty sure you're going to be covering that more whenever you do the sexually transmitted urogenital. All right. So this one, a good case. 14-year-old boy presented with a 3-day history of vomiting, diarrhea, sore throat, headache, weakness, and fever. His temperature was 39.9, which is very high. So now we have a rash location. It's not really a rash, we have a lesion. So they had a bike injury about 7 days ago. So they had the bike injury, and then roughly about 3-4 days later, then they started presenting with this more severe systemic infection. Up to date on vaccinations. We see a small crested wound had been noticed on the dorsum of his right foot. So that, I'm just going to go ahead and just sort of prompt you guys. That's the initial entry point. We see pharyngeal inflammation, and we see blood pressure is very, very low. So we're talking about hypotensive. And this is really good. I'm gonna put a star next to this. This is on Access Medicine. There's really good questions associated with this that I'm not getting into virulence here, but this is the actual case that I really recommend that you take a look at for your upcoming exam. All right. Okay. It was a challenging case, and I need more information. So I'm gonna actually show you guys that Staph aureus and Strep pyogenes are both possible answers. In the case of Pseudomonas, this one I'm gonna point out that really wouldn't be a consideration for a child. Pseudomonas is more associated with underlying infections or some sort of underlying immunocompromised. In the case of Clostridium perfringens, this is a question. So let's go ahead and come back. The viruses, these viruses are not really going to be causing a very severe, this is somebody who's septic. I'm gonna go ahead and let's come back to the case. And so here we see that with the bike injury, and so it was a local infection where the bacteria established itself, and that particular bacteria is able to really disseminate more effectively. How do I know bacteria? Because we're looking about the rough onset. We're seeing that we have a very, very high fever and that they are hypotensive. So they are, wasn't the test negative? Wasn't the test negative? I didn't give you the answer. So somebody just asked, wasn't the test negative? And so let me go ahead and show you how you could tell the difference for this case, because this could be Staph aureus and this could be Strep pyogenes. And so that's what I have them both as potential correct answers. So in the case of whenever you have Staph aureus, and so this is actually a situation where we're talking about toxic shock syndrome toxin. And so the bacteria is local, but this exotoxin, the super antigen, is actually systemic. And so I think the question, somebody just asked me, wasn't the test negative? If you do this case, it gives you the result that the throat culture was negative and the blood culture is negative. That's because Staph aureus can remain local. It's at the wound and it's secreting this exotoxin, which is causing the toxic shock syndrome or the toxic shock symptomatology. In the case of Strep pyogenes, it also releases a super antigen, it's called SPE, but it's not very stable. And in the case of Strep pyogenes, if that particular case where the bacteria got in from the wound, which you can absolutely have wound infections with Strep pyogenes, but then the bacteria has to be present in the blood or it might be in the throat. So if we have a blood culture and throat culture are positive, that would be turning this case into Strep pyogenes. But in this particular case, this is actually a Staph aureus case, and the blood culture and the throat culture are negative. The bacteria is here, and what it's doing, it's releasing an exotoxin that is a super antigen. So that's one way to tell the difference. Always, we would have to give you more lab tests to be able to differentiate between these two. But let me go and show you. Here we see gram-positive cockeyed, catalase negative, beta hemolytic, and we also say vasotrace insensitive. That would be my strep pyogenes. Also, we call that group A strep. In the case of if we have catalase positive beta hemolytic, and there might be a mention about coagulase, that's another way that we can tell the difference between our Staph aureus and strep pyogenes. They're very hard to tell with the skin infections. And so the professor, the vignette, there has to be something with the lab study. So I just wanted to give you that case because Staph aureus and strep pyogenes is very much associated with lots of different skin infections. In the case of Clostridium, I'm gonna just X out that particular Clostridium perfringens. We're not going to be seeing some throat inflammation. It can cause sepsis, but most of the time you're going to be seeing a lot more necrosis at the particular site of infection. Clostridium perfringens, it doesn't spread as effectively as, say, a strep pyogenes. Same thing, Staph aureus is local, but its toxin spreads. And Pseudomonas we ruled out because the child is not immunocompromised. Pseudomonas can cause skin infections in healthy individuals, such as hot tub folliculitis. But if we see a deeper infection that there's septic, we're really going to ask, are they immune compromised? Okay, so very important, the gram-positive algorithm, just go ahead and put an exclamation point. I would sketch out for Staph aureus, strep pyogenes, Clostridium on your upcoming exam because the cases are so difficult to tell apart. Okay, so here's another vignette. A Colombian man, it was in his 70s, presented with history of light-colored rash, weight loss, fever, decreased appetite, night sweats, and a new cutaneous ulcerations involving his arm, legs, and abdominal wall over a 4-week time period. His wife had similar lesions on his back. I'm going to go ahead and point out this is a really important clue. And so we see hypopigmented confluent macular rash is noted on abdomen and extremities, and we've seen numbness and paressia. So this is actually an actual case. It is a co-infection. And so I'm going to show you about 2 different possible answers for this one. Okay, the correct answer for here is, this is actually Mycobacterium leprae. That hypopigmentation is talking about tuberculoid leprosy. And so they're going to be flat, and that loss of sensation is really important. Fungal, I'm going to show the differential by this. The ulceration, that can actually be caused by a fungus. So I would want to test these actually ulcers because of that duration. The actual case is Mycobacterium leprae. However, it is actually a co-infection with Mycobacterium tuberculosis. And so I had to check whenever studying. I put the links for it. You do have to just have a free sign-in for these infectious disease cases. But I would be asking about, is the fungus causing the ulceration? But these hypopigmented confluent macular rash with loss of sensation, that's very characteristic of leprosy. So the Mycobacterium leprae, it's an acid fast bacilli. But let's go ahead and look at the different case. And so here we see 32-year-old South African male presented with a 3-month history of painless, and this is an important clue right here. There's no change of sensation. A hypopigmented rash predominantly on his upper chest and shoulder. This particular individual, they're HIV positive. And so we're talking about a co-infection that's occurring. We see hypopigmented rash is noted. No regional lymphoadenopathy is present, and the patient responds to touch stimulus. And so I just took that leprosy case and I changed some details of it to change the answer. So hopefully you guys will get this one. Yeah, absolutely. Go back. Okay, yeah, absolutely. The correct answer for that one is Malaysia fur. It's going to be a superficial superficial cutaneous, and we're going to be seeing, it's called spaghetti and meatballs. And so it looks kind of like this. So whenever you do the skin biopsy, but the fact that we see hypo or hyperpigmentation, it's really common in the tropics, but it's going to be Malaysia. I think I'm misspelling it. Malaysia. And so these two are really important differential. Mycobacterium leprae, it's an acid-fast bacilli, and it causes loss of sensation, as well as it can cause some neuritis, versus tinea versicolor. And individuals actually in some developing countries get misdiagnosed. They have a fungal infection and they get misdiagnosed as a leper, and they have to go live in a leper colony, where this is a very, very easily treated fungal infection. Okay. All right. So doing good on time. A 66-year-old white man underwent surgery for colon carcinoma, and 2 days later, he experienced severe pain at the surgical wound site. Within several hours, local edema and tenderness developed at the wound, as well as thin brownish discharge. Really want to ask about, yes, he has a colon cancer. We want to know what antibiotics that he was on, because that might also influence the onset. I'll go ahead and say that prior to the cancer diagnosis, this is a healthy individual. They really aren't immune compromised aside from that single colon cancer. We're seeing discoloration of the skin, hemorrhaging bulbae. This is from the NAC casebook, by the way. The affected muscles show failure to bleed. So we're starting to see some myonecrosis. Extensive gas is present in the soft tissue. Okay, yeah. Why it could be strep pyogenes, which is associated with surgical site infections, but whenever we see anything mentioned about gas, strep pyogenes is not going to be producing any sort of gas byproducts, versus Clostridium perfringens, it's going to be an anaerobic bacteria. And so these two are the two top differentials, but whenever we mention about crepitus, or sometimes it's described that there's like a creaking sound whenever you have manipulation of the muscle. So Clostridium perfringens, that's actually the causative agent for this. And strep pyogenes could present like that. You don't have to wait for me. You can go. Sorry. Working at home. Yay, cats. Yay, husband. It's cool. Whenever we see that crepitus, that's going to be Clostridium perfringens. Always remember that it's spore forming, as well as there might be mention about foul smell. It's going to be really, really gross because it's an anaerobic organism. Spore forming anaerobic organism. So let's change the case. We have underwent surgery, but now we're seeing a thick greenish discharge. And so the color is a little bit different. Underlying health conditions and preventative antibiotics. The patient is obese with uncontrolled diabetes. The discharge is a purulent discharge with a distinct fruity odor. And so that's that's going to be really important. Sort of what is the patient's history? I just lost my pen. What is the patient's history? Well, the patient has really underlying immunocompromised status. I just want to point out that preventative antibiotics, a lot of times we're going to put somebody on a beta-lactam, such as amoxicillin or ampicillin, and that's going to help out with strep pyogenes. And so, especially if we're going to get, if we're doing some sort of GI surgery, we're going to give them something like an ampicillin. And so that's going to be preventing the development of the strep pyogenes. But then we're going to have a situation that if we give them an antibiotic that doesn't cover a drug-resistant organism, that's going to change what we'll be considering as our differential. Okay, so there's a lot of different options for this. And absolutely, if you had this case, you should be doing lab staining. You would be doing gram staining. And so if we had, gram positive cocci, that would be leading to these correct answers. Or if I have a gram negative bacilli, that's going to be Pseudomonas. That's actually the correct answer for this particular case. Let me come back to show you. We're seeing this greenish. Anytime that we see something about a really green, that's going to be, as well as that distinct fruity odor, that's Pseudomonas. Pseudomonas, once you become a clinician, you will know what the smell of Pseudomonas looks like. It's almost like a fruity smell. In the case of Staph aureus, you don't see a lot of times a smell for the discharge. Even in the case of Staph aureus, it's not going to be as stinky as such as Clostridium perfringens or sweet smelling such as Pseudomonas. So that actually becomes sort of a superficial clue, but that greenish discharge is the pyocyan, and we're just showing an image of it. If it were Staph aureus and Strep pyogenes, that would be more of a yellowish pussy. In the case of whenever we think of Pseudomonas, is absolutely a green one. Green color is referring to the pyocyan, absolutely. So the correct answer for this one was Pseudomonas. And as well, I was really stressing that before with a child. Pseudomonas doesn't cause really severe infections in immune compromised individuals, but people who have underlying conditions, especially diabetics, who really have their physiology, it's really, it allows this opportunity for this organism to establish itself, and it can lead to a sepsis. So here we have, you don't need to know this so much right now, but we have a gram-negative bacilli. It's a lactose non-fermenter that would be on McConkey. It is motile, but I just want to point out it's oxidase positive. That's a really important clue. So gram-negative, oxidase positive, that's really going to be a major lab clue that we'll think for our Pseudomonas. Okay, I am at 143. That's it. What I have, I just want to point out, this is really good. The Lane case files is on Access Medicine. We only have a handful of them. On Access Medicine, they do have the Sherris cases that are good for the differentials. I sort of rooted through them. Read the Staph aureus one that I linked out because it asks you specific mechanisms of our virulence factors. Are the term fifth and sixth disease commonly used? Fifth disease is parvo. I don't remember what sixth disease is, so if I don't remember it offhand, fifth disease, yes, that's parvo. That is commonly used, but not usually. Most of the time, we're going to be describing the xanthum, the presentation. Okay, yeah, and that's what I have for us today. I really recommend looking at the Infectious Disease Society cases when you can, just to clarify. Furnicle referred to a folliculus that's invaded deeper down to dermis. Yes, absolutely. So once it's in the follicle, and then it starts spreading. Just kind of think of an abscess that's now passing just the hair follicle. A furnicle is 1, a carbuncle is 2. Will labs be provided in questions? Yes, absolutely. And that's what I didn't get into labs, but I provided you with the algorithms to anticipate what labs that you would see for this one. So yeah, our style for the USMLE's vignette style questions, for Dr. Rainier's questions, they're going to be having the labs provided. Okay, I'm going to go ahead and stop video. And where can we find this file? I'm going to upload this. I don't have access to PCM 1 material, but it's going to be in BPM 3. I'll provide the file as well as this lecture recording if anybody else wants it. So thanks for coming.